on your own, you know, and some people don't get it done. You know, some people go somewhere else, but most do get it done, and so I'm adamant. And then the other thing is on the website, if you go to patientanimations.weebly.com, you'll find a website that's got all this stuff on it, because I don't know where this girl is, you know, in my computer system. You know, she's somewhere in there, but I don't remember her name. I remember doing the case. So we went and found all of our good cases that represent everything we do, and we put it on the website. So when Tammy has somebody that comes in that's missing 4 front teeth or 3 front teeth, needs to have implants and a fixed bridge, she goes right to the website, fixed options, and shows this case. And then the patients get it. You know, she went through braces, we did these implants, custom abutments, 4-unit fixed bridge, and then they understand, you know. And we want to show them what a splint is, because this guy had all this nice, had implants done, all this nice dentistry by Dr. Mike Malone, you know, got real nice occlusal stops and all that, but we need to protect your work. That's what the guard's for. And so these cases are on the website, you know, so it just shows before and after. And in that way, patients can kind of understand what you're talking about. This is a young girl, Adderall, we were talking a little while ago. Everything had to come out. Straumann implants on top, Straumann on the bottom, snap-in lower overdenture, snap-in maxillary overdenture. I don't know why that's there. But this case is on the site also. This lady comes in and says, I didn't think I could have implants done because Dr. Malloy took out a tumor and then they put this thing in here. And I said, well, you know, you got plenty of bone. I mean, this case would be easy as they come. And I mean, just changed her whole life. You know, now we got these, I always tell them, like, because some dentists will say, well, look, we're just going to put in 2. Well, the problem with 2 is the denture is going to rotate on that axis. And a lot of patients are like, you know, I paid you $5,000, and now the denture still moves and all that. I just tell them, look, 2 is like a bicycle. It can tip over. 3 is like a tripod. But 4 is like a 4-legged table. The more we spread the legs out, the more stable the table is. So if we get something like this, man, this is a slam dunk. I mean, these patients are so easy to please. They're so happy. The denture's stable. It's not often that we have that much bone left in the posterior mandible, but that's why I'm an advocate of socket preservation. So we're taking out back teeth. You know, let's curette the sockets out real good, fill them with graft, put a membrane over that, let these areas heal up, and so that we can put implants further back and not just be stuck in the front. Here's another guy that really has a lot of bone. Okay, so we've got, these are not custom abutments, these are prep stock. You know, we don't do that anymore. But just to be able to show patients representations of everything that we're doing now. Before we went to the AnyRidge implant, we were using the Rescue implant, and that's how I met Joel. I was in San Diego to American Academy of Implant Dentistry meeting, and I saw this thing, and I said, man, this looks neat. So we take a molar out, put this guy in. They work well. AnyRidge is better. They're just better. Okay, but for the time being, you know, it was a good. Who is this? Who's that?
I don't know. It was in Korea.
Okay. So here's an example of using this Rescue implant. Like I said, nowadays I would use the AnyRidge instead because of the thread design and so forth. But this has worked out well, you know. And so here we took out these 2 molars. These were placed immediately. This is the case after it was not restored yet. So she had some other stuff. We use every brand. Tapered screw vent, Straumann, tapered screw vent, Straumann, Rescue. You know, this is a patient's in progress. You know, she's had some work done years ago when she has another issue. She comes back from Patterson, Louisiana. But I like these things, and I really like them a lot. And Joel, after lunch, we're going to start off with you talking about the features of the system. I'll show you a little bit about it, what I know. But he's much more knowledgeable about the technical stuff. This, to me, looks like a sheetrock screw. And when you put it in the bone, it takes an incredible amount of torque to seat these things. And if you put like this implant right here, 7 millimeter, and you try to put it in the mandible, you're not going to get it all the way in. I mean, it's just not going to happen because the bone is so dense. So you're going to want to use a narrower diameter in these molar areas unless it's an immediate placement. But, you know, nowadays there's so much hype out there about what's going to be the perfect implant. We're looking at platform switch. We're looking at stock abutment designs. We're looking at at this deal right here, whatever that is. Here we're looking at the pitch of the sharpness of the threads, which I think is a big deal. And so, you know, in the last couple of weeks, I've removed several first and second bicuspids, and all I did was take a 3.8 millimeter diameter drill and just refine the apical part of the socket, and then screwed it a 4.5 by 11.5, just done, finished. You know, and when you're putting that thing in, you're thinking, man, this is solid. I mean, this is serious. Instead of, now I've got a machine screw that really isn't tapered, and now I'm packing bone around it and doing all these things. I'm going to put a temporary on right away on this other deal, you know, because the initial fixation is just that great. So you've got this double offset for a better peri-implant biotype in this area here. Real narrow core. So we're not drilling a 7 millimeter hole. We're only drilling a 4.8. And the 7 millimeter implant is going to go in to type D3 or D4 bone. It's D1 bone. Then we're going to probably put in a 5, maybe, you know. So there's a little bit of thought that goes into the process of placing these, but it's kind of one of those things that once you kind of get the knack of it, it kind of just starts to make a lot of sense. And as I said before, these are knife thread like flutes on these things, so particularly maxillary bone, it really works out well. These are some of the cases that were done in 2011 when we first started using. How long has the system been out?
Worldwide, about 4 years now.
Okay, so these were done in 2011. Taking a molar out, dilate the furcation bone. This thing goes in solid, solid, solid. Really nice. Here's a case that was done on a physician. It was a friend of mine. This is all he had left. So we took the SLA drill from Zimmer, made a window, put all our graft in there, let it heal about 5 or 6 months. Then when it's time to place the implant, I noticed that it had a really deep pocket on the mesial, this third molar. So we took the tooth out, grafted the site, screwed this in, and I'm telling you, this is just as solid as it looks. I mean, the day you do it, you think, man, we ought to just take the impression now. But instead, I'll wait 2 months, make an impression, make a custom abutment, and then just go ahead and restore it. Same thing here. Took this tooth out, dilated the furcation bone. Sometimes we'll do that using a bone spreader, or in fact, a lot of times I'll use one of those motorized bone spreaders to where you're going in at 50 RPMs and it's just drilling, it's creating an osteotomy, then you back it out and go to the next diameter and then screw this guy right back into place. So like I said, you know, here 3.3 millimeter diameter core, 4.8 millimeter diameter core. This is going to go into D1 bone, and these are going to go into D3 and 4 bone. Same thing down here. This goes into dense bone. This goes into bone that's not so dense. So it's pretty slick. And the thing that I took this picture at the office because I put all my cup holders in on the wall with machine screws, and they're all falling out of the wall. You put a screw in like this, it's not going to come out. So we talk about osseointegration. It's amazing. If you have an implant with 50% bone loss, a tapered screw bed, you can get in there, put your thing in, get your socket wrench, you can back it right out. I don't care how long it's been in. You know, and I've done it a bunch of times. If you put one of these in and you got to take it out, you got a problem. You're not going to get it out. I mean, you're not going to get it out. After 3 months, it ain't coming out. And so the only way to get it out is you're going to have to get in there with a burr, a liniment burr or something like that, and get rid of these guys so that you can back this thing out. We had a guy named George Seifer who's he's another story. Anyway, 8.5 millimeter implant. He lost about 3 millimeters of bone initially because he was, I don't remember what the problem was. Just didn't heal well. And I said, look, we got to take this thing out and put another one in. Couldn't get it out. So the maxilla, 8.5. We got 3 millimeters of bone missing. So we only in there 5 millimeters. It'd been in 3 or 4 months. I could not get it out. And so wound up cleaning the threads out, grafting and closing it back up. But I guarantee if it was anybody else's implant, I probably could have got it out of there. So that's, you know, as far as getting initial fixation in cancellous bone, this really it does the trick. There's another implant they have called NE1. I'm not using it, so I can't really comment on it too much.
That's mainly for dense bone.
It's for dense bone. Okay. Here's an example of those type implants. And we're going to be taking a break. And you said 11:30?
We can go now because I got to do a little bit of...
Well, I'm going to finish this and then we'll go. Okay? So we talked about the Prexion. Here's a rescue implant. Worked out real well. Then when it's time to replace this guy, we go to this. All right? And I just like these things quite a bit. We already saw that slide. You look at this thread into this bone, and just try and imagine, how rigid that is compared to something that resembles a machine screw. It's just like a night and day difference. Same thing here. And so the fixation is really remarkable. Here we're using the Prexion. We're looking at the amount of height and width available. There's our AnyRidge implant in that site. And this bone, a lot of times, is like I said, it's just like balsa wood. And to put a tapered screw vent in there, when it was time to take the healing screw out or put the abutment in, I was always scared. I was always thinking, you feel that? You feel that? With these things, I don't ever say, are you feeling that any? Because you know that thing isn't moving. And that's a quantum leap from where I've been over the last 20-something years. Y'all ought to put me on the payroll. Anyway, so this is my brake picture. So let's go ahead and, no, I'm not there yet. Almost there. I'm coming there. So after the break, we'll talk about immediate molar placement. This might even be Daryl's slides. Are these yours?
Yeah.
They are? I thought so. Well, I don't do the little thing. That's you. So we use a Lindenman burr to section these, elevate the two root tips out. Okay. Got that out of there. So this is mine. That was Daryl's. But I want to. So here's a molar. Looks like is that an upper or a lower? Lower molar. So Jim Hutchinson. So we're going to section this. We're going to take these roots out. We've already done that. This is a motorized bone spreader. Blue Sky Bio has them. Drawing a blank. MIS has them. Messenger has them. There's several companies that make these things. So what we're going to do is we're going to go in that furcation bone with the smallest diameter one first and go ahead and create an osteotomy using the motorized bone spreader. 50 RPMs forward, then back it out. Go to the next diameter, then place the AnyRidge implant in that dilated furcation bone. There's placement. These pretty poor photographs. Then we've added fusion bone binding, freeze-dried bone, then PRF membrane over that. Most importantly is this right here. It's a cytoplast membrane from a company called Osteogenics. I use that 100% of the time now when we bury implants, because you don't have to release these flaps to try to draw the tissue together. You can leave the tissue right where it belongs. And then after 6 weeks, we take the sutures out after maybe 2 weeks because of Gore-Tex. After 6 weeks, we just pull this membrane off, and it's just like pulling a tablecloth off, and it's just like attached tissue. And I don't even know how it works. Do you? I don't care. It just works. And all that other stuff that's out there that we've tried over and over again, here we are dilating the furcation bone, put this in place, add our graft, put that membrane over that, and it's a done deal. I mean, it really works nice. Here's another one. This is a shame. Tony Rainwater, a friend of mine, did this root canal, man. She was so symptomatic for like a year and a half. It looks perfect. We never could find anything wrong with it. Took the tooth out, dilated the furcation bone, motorized bone spreader. Here's the implant before the graft was placed. Then we've got all our grafting done. It's a case I showed y'all earlier. But this is what I want you to see is it's a cytoplast single. These are $35 a piece, so it's not real expensive. And after 6 weeks, you just pull the membrane out. You don't even use anesthesia. It's like the Gore-Tex, the tissue would grow into it or whatever, and you had to get in there and dissect it out. And I didn't really have a lot of experience with that. But this right here, you just pull it right out of there, and now you've got all the attached tissue in the world. Let the implant heal for another 6 weeks, and then go back and expose it surgically. A lot of times you use a diamond burr to do that, because you have plenty of attached tissue. The Oral Flurry, he used to be with Straumann. Then he was at Tomlin Medical. Now he's with Implant Direct. He was in my office the other day, and he goes, man, you ought to think about getting this CO2 laser. I was like, what for? He goes, we're exposing your implants. I said, how much did that thing cost? It was like $60,000. I said, nah, I got a burr. It costs $1.50. And all I'm going to do is wipe. I know where the implant is, and I'm going to numb it. I'm just going to wipe that tissue away to find that low healing collar, back it out, and screw in my impression transfer, take my impression. Just so easy. Easy, easy, easy. In routine, every day, every day. This is a pharmacy in Houston that is making the bone binder for us. You got to try it. It's just, I mean, we use it every day. I was spending $3,700 a month with my cousin before we quit doing it. And then this guy is cheaper than my cousin was. So, so I just ordered a bunch from him. If you order one graft set, it's $30. If you order a bunch of it, it's $15 per set. It's got gentamicin antibiotic in it. It's got alpha carboxymethyl cellulose, calcium sulfate. You have 2 Lure-Lock syringes. You lock them together. You mix it back and forth. Squirt it in a damping dish. Add the freeze-dried bone. Mix it up, and you've got a putty. And it just really, really works nice. If you want to get a set of bone spreaders, these are the ones from Blue Sky Bio. So you're starting off. You've done your pilot drill at maybe 1.7 millimeters in diameter. Then you introduce this at 2.6, 3.0, however size you're going to. But rotate these at 50 RPMs at about 50 Newton centimeters of torque. And they really are nice. And so we were talking earlier about sinus elevations. Sometimes I use this to elevate the sinus, you know, because it's blunt and it'll push the thing up instead of the hammer thing. Yeah.
You mix that when you're doing a socket preservation with the.
Yeah.
You mix that with the blood.
No. Gentamicin antibiotic is in one syringe and the powder's in the other. So when you lock them together, you go back and forth and it mixes them up. You know, I guess like Atrodox or one of those perio deals. What was that stuff called? Is it Atrodox? There was something you mixed up like that in perio a long time ago. I can't remember what it was called. But so what were you saying?
So you just mix it and then put it straight into the socket?
Put it in a damping dish, then add your freeze-dried bone. It's a bone binder. You can put anything you want in there, whatever the bone graft du jour is. Some people use corticals, some use cancellous. We use 50-50. Some people want to use, what's the bovine stuff called? Bioos. You know, or some people use half of that and then half of something else. It's the bone binder doesn't really care. It just makes whatever you've got as particularly in a putty. Yes, sir. Yes. Only as a barrier. So if I wasn't using PRF and I wanted to, or pericardium collagen membrane, you can mix up calcium sulfate and you want to try to get a 2 millimeter thickness and you hold pressure on it until it sets up hard. You got to be careful suturing because if you dislodge the cast, it'll break or it'll move, or if they can't wear a denture over it. So it's a little tricky, but yeah, we do use it less and less because I use this all the time. I mean, it really works well. I've been using it for 10 years.
That's not what that is, calcium sulfate.
It has calcium sulfate in it, but it also has alpha carboxymethyl cellulose and gentamicin. And in other words, it doesn't set up like a brick. You know, it just maintains sort of a putty consistency and it stays put. You know, they come back after a week, you're not looking down in a hole and wondering where all the all the bone graft went to. Yes, sir.
I know they recently had a flood. Yeah. I made it out. I know they recently had a flood. Yeah. I know they recently had a flood.
Yeah. I spoke a little bit about digital scanning earlier today, and I'm kind of down on it right now, but just to show you what it's all about. It's kind of one of those things that maybe I'm just being negative, and I don't feel like fooling with this thing. Danny's kind of into it, but this is a Trios 3-shape deal, and the things to look at is a cost consideration. It's a $40,000 investment. If you buy the one from 3M, theirs costs less, but it's a $500 a month support fee. I mean, it's kind of one of those things. It's like, man, I could have bought a car, you know, for what we pay for this thing that I'm not even using. We have to look at what are our goals for having this technology. Well, my partner wanted to have the scanner, but he's not using it for crown and bridge at all. He's just using it for implant abutments. As far as time and efficiency, you know, if we screw in an impression transfer and take a triple tray or a full arch impression, you know, that still seems to work pretty good. So is it really profitable? Is it really necessary? Sure, there's a wow factor. It's very impressive. But my conclusion right now is I'm not so sure that this is something that you can't live without, you know. And so I'll show you what it looks like. This is called a scanning abutment. And so basically they've unscrewed the healing collar. This is the deal right here. We've got 2 assistants in the office that are very good with it. We have some of them that they just can't even use it. And so, Danny's real optimistic, but when I talk to the assistants, they all say they hate it, and I want them to do it. I don't really want to do it. And so I find myself kind of going back to using impressions. But it is pretty slick. I mean, it really is. Here's the scan. This is what the laboratory sees when they're designing the abutment. They go ahead and print out this model, and this is a zirconium abutment on a tie base. And this is what comes back. That's just a close-up of it. And so here's the tie base. Here's the zirconium abutment. So it's pretty slick, to get this back and then go ahead and take your final impression for your final crown, or you could really have the crown made at the same time if you wanted to. I believe that's a provisional restoration. And so that's kind of been our experience with digital scanning. I hear positive things from other people that are doing it, but I'm kind of I just look at time and motion, and I just don't see that it's there. I don't see that it's saving us very much time. I don't see it saving us much money at all. For that kind of investment, for it to pay the return on investment on that, I don't know if I'll see it in my career. So I don't know. Maybe it'll get better. Okay. Any questions about that? So next thing we're going to go to is complications. Like I said, we're not going in any kind of order today. I'm just kind of jumping around as the Spirit moves me. And so we'll talk about this. Because complications are going to happen. I showed this earlier today. This is like 6 years post-insertion. We can connect that with a connective tissue graft. An ounce of prevention is worth a pound of cure. We should have seen this tissue when the case was done, but this is something we can fix. I showed this earlier today. This case is 20-something years old. We talked about all the treatment options. She left it alone. She's low lip line and so forth. This I found this on Dentaltown, and I think they threw this guy under the bus pretty good. I think what happened here was they put a mini implant in so the patient could have a temporary until they became of age to have a real implant done, but probably got lost in the shuffle. So these teeth all came down. This stayed way up here. So in spite of those good intentions, I think a Maryland bridge, which is what I do, if somebody's 14 or 15 years old and they're missing a tooth and they can't have an implant now, I just take an impression, make a Maryland bridge, and put it in with CNB Metabond cement. And when it's time to have an implant done, cut it off, knowing that it may come off once or twice between the ages of 14 and 18 or 15 and 19 or whatever it is. But that just seems to really work out in terms of holding them together. I already showed this case already where the complication was they didn't have a scan, tried to do this flapless. It's quite the craze in the mini implant business to do things without a flap. I've done so many cases where I would think, man, I bet I could do this without a flap. And then I make an incision anyway. It's like, oh, Lord, no idea. And then with a scan, at least you know ahead of time. But if I was doing mini implants, I would always lay a flap unless the ridge was real wide. And if the ridge is real wide, there's a good chance that you're dealing with a lot of cancellous bone, and you're not going to get good initial fixation with these mini implants. So it's probably not a good idea anyway. So my conclusion is, if I'm going to place a mini implant, I'm going to lay a flap. I want the attached tissue out of the way. I want to be able to see the bone. And like I said, we don't really do that many of them. So anyway, she's fixed up now. That was a complication. As I said earlier, I printed this out and I attach it to every lab slip, because when they send back implant crowns that look like this, patients get food caught in there and they complain. Now that's a little bit of an exaggeration, but the idea is that embrasure space has got to be kept to a minimum so that food doesn't get caught in there, but it needs to be wide enough to where they can get an interproximal, one of these little small interproximal brushes in there. So this is like 1 week of complications in my office. This is Steve Swallow. This is I took the crown and the implant. No, this was back. Let's see. This was done in 1998. This is 2014. Pure titanium implant, 3.3 millimeter diameter. Look how thin these walls are. Snapped it off. I've gotten good at removing these because I've taken out about 12 of them. And basically, it's using a long Lindemann burr and going about halfway down and creating space, enough space to put an elevator into, and you just elevate, and then you get the thing out of there. And we come back and put an AnyRidge implant in the same site. This happened, let's see. Okay, this was the same week. This has been in place for like, I don't know, 12 years or something like that. and the guy comes in and the whole thing's loose. So it's been fine for 12 years. So here's what happens. I wound up taking this, this came out, we went and put this back in, which is going to have much better primary stability and adaptation than this ever would. But what happened, and this is the same week too, you were telling me about all-ceramic abutment? This is a Zimmer all-ceramic abutment, okay? So we went from this to this, but what happened is this. This is what the guy looked like a while back. Well, in the meantime, this crown came off. He had a bunch of decay. This had to be taken out. This crown was broken. And over here, he had seen somebody else, and this tooth was replaced with an implant that was not in function. So this guy right here was hammering away at this guy right here. Otherwise, I really think this would have been in place for the rest of his life. So once again, we really have to watch occlusion closely, particularly in these maxillary posterior segments, because that's where you're going to find loss of integration over time, and even in the upper anterior area, because they start losing posterior support. This is like Mike Tyson with an uppercut into these teeth, and if it's an implant-supported crown and you've got good hard occlusion on it, you can lose integration over time. This is a case that I'd done a long time ago. These are Calstech implants, and I can't read the dates on here, but this was done in the 90s. And so Calstech, two in the front, and then this guy right here. Well, this lost integration, okay? So we take this out. You can see before we remove it, it's got this nice space around here. Put this guy in, curetted this out real good, washed it out real good, put this guy 7.5 by 10 millimeter height. This was a 4.1 by 10. So big difference in bone to implant surface adaptation. And basically got rid of the bar, put locators on all of these, and then a locator attachment back on this one that we replaced. So as I was mentioning earlier, serviceability is important because things are going to break, things are going to happen, and we've got to get real creative and thoughtful about what are we going to do when this happens. I see a lot of broken screws and broken implants and broken abutments because we've been doing this so long. So I see stuff from Mexico, from all over the place, and it's not real profitable, but it's neat when you can fix some of that. I saw a patient the other day of Steiner's, and what had happened was they put in 2 Brandemark implants, and they put in 2 non-hexed abutments and 2 splinted crowns, which is fine. Well, one of the implants fails, so they cut it, took that implant out, put it in a Straumann and a single crown. Well, then Dr. Cates was seeing it in Lake Charles. Well, the back crown is spinning around now. So we don't know what kind of implant was done because it was done in Houston, and the guy's out of practice and how many charts and all that. And this is a mess. It's a real mess because people don't have records, and we get cases where we call the office, they don't know where the chart is, they don't know what kind of implant it is. And it's like, so you're staring at all this hardware and you try to figure out what to do. Well, fortunately, it was a 3.75 external Brandemark hex. So I went to one of these catalog companies, Diamident. They got everybody's stuff. They have, what do you call that, aftermarket parts or something like that. So I ordered a Brandemark 0 degree straight abutment, got her in, screwed it right in, and it's engaged in the hex, and I'd send it back to Tom so he can make a crown. But this lady, has got a perfect implant down there, but no way to fix it. It's been spinning around for months. So here's one of my cases. These are MTech implants that were done back in 1998 or 99, something like that. These are HA-coated implants. This lady was pulling out of La Fonda's. You know where La Fonda's restaurant is in Lafayette? It's got the best margaritas in the world, and they're dangerous. And she was pulling out of La Fonda's, and some guy hit her head on. He was drunk, knocked all her front teeth out like a week before her high school graduation. So she's been wearing dentures all this time. We did some augmentation, came back, did these implants, did a bar. It's been in there forever. But one day she comes in and look at this. So what's happened is we've lost some integration here. There's the weak link in the implant, so it snaps off there. So we dig that thing out, do an antral lift, also lateral perforation here. Whenever you see a smokestack going like that, that means that you got a little hole there. Anyway, healed up fine. This is a rescue implant. And what we did was we waxed up and cast this up, okay? Because I don't want to remake her bar, and I don't want to remake her overdenture. And she doesn't want to either. And I said, look, what I'm going to do is we section the bar right here. I took an impression, had this cast up, all right? So this goes into the rescue implant, all right? And I'm going to cure these together in the mouth. investment, sandblast, flux, solder. There's our existing prosthesis. We took the Dola clip out on that side.